The Academies operate under a congressional charter to the National Academy of Sciences that was signed under President Lincoln in 1863. So for each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study statement of task. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. So I have with me today 3 members of the committee to discuss the report's findings and conclusions. But before we introduce the committee, I want to go over a few technical aspects of the webinar. So after the opening remarks, we will begin to take questions through the Q&A box located in the lower right-hand corner of your screen. You simply type in your question into the box at any time and click Submit. And I ask that you please leave the box set to send your questions to all panelists. And if you have any technical issues during the event, please contact WebEx Technical Support at 866-229-3239. Again, that number is 866-229-3239. So as I said, joining us today are 3 members of the committee that wrote the report. First, we have Donald Steinwalk, Chair of the committee and a professor in the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health. Also joining us is Ana Diaz-Rue, the Dean of the Dornstein School of Public Health at Drexel University. And also joining us is Meredith Rosenthal, a professor of health economics and policy at the Harvard T.H. Chan School of Public Health. Joining us as well is Kathleen Stratton, the study director for this report. We'll start off with the committee summarizing the report, and then we'll open it up to any questions that you may have. So please note that this briefing is scheduled to last for 1 hour unless we run out of questions beforehand. And with that, I'll turn over to Dr. Steinwalk.
It's a pleasure to be with you today and to talk about the 3rd report in the series of reports this committee has put forward. I will be giving you a little background on that and introducing it, and then we'll move into the content of the report. The next slide gives you a list of the committee members, and this has been a committee that brings together a wide variety of skills that have been critical in our ability to assess social factors and to think about how they might be used by Medicare. The first report that the committee came out with, next slide, oh, you've got that, thank you, is one in which we looked at what social risk factors should be thought about and included in trying to account for social risk in a Medicare or other payment program. The major step that we took in that report was to develop a conceptual framework. And if you look at the next slide, you will see the conceptual framework, and it's our effort to relate that to 3 areas of outcome: healthcare use, healthcare outcomes, and resource use outcomes. The social risk factors are aggregated in 5 categories. 1, socioeconomic position. Secondly, race, ethnicity, and cultural context. 3rd, gender. 4th, social relationships. And 5th, residential and community context. You also see on there health literacy. We do not consider health literacy to be a social risk factor, but do recognize, as recognized in the legislation that initiated this report, that health literacy does have an impact on some of these outcomes, but health literacy is not a social risk factor by our definition. The second report that came out, next slide, was to undertake an effort to try and make some contrasts between hospitals and health systems that serve socially at-risk populations and the extent to which we could learn about what makes it more successful to do so. We found, as we went through the literature, that indeed there's very little literature in the published literature. But what we did find was that there were case studies. And so we were able to bring together a series of case studies looking at organizations that serve people with social risk factors and try and identify what are critical aspects in doing that more successfully. On the next slide, you'll see what we talk about in the second report as system practices. And it shows you a circle. Inside that circle is focused on community-informed and patient-centered care. And the practices surround that. The first practice is a commitment to health equity, which defines globally our sense of what needs to be done in order to make health care and access to it and outcomes, ideally, equitable across the population. The other 5, data and measurement, comprehensive needs assessment, collaborative partnerships, care continuity, and engaging patients in their care, are processes that aren't sequential, but they are key processes that successful providers, hospitals, and health systems use in order to be able to provide better care in communities and to individuals with significant social risk factors. So let me bring you now to Report 3, which is the next slide, talks about the statement of task that is what the Report 3 addresses. And there are 3 categories in this report. The first asked the committee to specify criteria to select social risk factors that should be accounted for in Medicare quality, resource use, and other measures to be used possibly in Medicare payment programs. So we'll talk about criteria. Secondly, to identify SES factors or other social factors that could be incorporated into quality, resource use, or other measures used by Medicare, so that could actually be part of the measurement system. And third, identify methods that could be used in the application of SES factors, other social factors, in payment programs that would allow an adjustment for that. Let me turn now to give you an introduction to the goals we have for Report 3. And you'll find that on this slide we talk about 4 goals. If you look at our goals in terms of reducing disparities in access, quality, and outcomes, and quality improvement and efficient delivery of care, you'll notice that 3 and 4, fair and accurate public reporting, and compensating providers fairly, which talks to adjustments potentially in payment, those last two, really are the ones that will help drive reducing disparities and quality improvement. I would like to turn now to Anna, who will be talking to you about the selection criteria.
Thank you, Don. So as Don indicated, the first task that the committee engaged in for this report was identifying criteria for selecting social risk factors. And the overall aim was to develop criteria that would guide the selection of social risk factors that could be accounted for in value-based payment in order to reward providers or health plans for delivering high quality and value independent of whether they serve patients with high or low social risk factors, and also to promote accuracy in reporting by minimizing the effect of factors outside the provider's control when assessing provider performance. And so the first conclusion of the committee was that it was possible to identify 3 overarching considerations that in turn encompass 5 more specific criteria that could be used to determine whether a social risk factor should be accounted for in performance indicators used in Medicare value-based payment programs. And the first of these overarching criteria is that the social risk factor is related to the outcome, to the set of outcomes that Medicare is interested in. And of course, that has 2 components. One is the presence of a hypothesized conceptual relationship that, a rationale for why this factor would affect the outcomes. And secondly, a confirmation of that relationship using empirical studies. The second overarching consideration was that the social risk factor precede the delivery of health care and not be a consequence of the quality of care received. And so two more specific criteria within that overarching theme is that the social risk factor be present at the start of care, and that the social risk factor not be easily and directly modifiable through the actions of the providers. And the third overarching consideration was that the social risk factor not be something that the provider can easily manipulate in order to game the system in some way. So this next slide shows the conceptual framework that Don showed you, and it's expanded to include indicators of each of these 5 broad domains that Don identified: socioeconomic position, race, ethnicity, and cultural context, gender, social relationships, and residential and community context. So as you can see, health literacy in this conceptual framework is positioned more as a consequence, at least in part, of these social risk factors, and as something that is potentially modifiable directly through the actions of the providers, through the care received. That's why you see that dotted arrow going back towards it. So in the second conclusion, the committee agreed that there are actually measurable social risk factors that could be accounted for in these payment programs in the short term. So we identified indicators in each of these domains. So within the socioeconomic position domain, we identified income, education, and dual eligibility as a rough proxy for socioeconomic position. We also identified race, ethnicity, language, and nativity within the race, ethnicity, and cultural context domain. Within the social relationships domain, we identified marital or partnership status and living alone. And within the neighborhood, residential community context domain, we identified neighborhood deprivation as well as measures of urbanicity and housing. The committee also concluded that there were some additional indicators of these 5 broad social risk factor domains that do capture complementary aspects of these underlying constructs, but that currently present some practical challenges, but to be, specifically utilized at this point. But they are worth further attention in the future, as there may be ways that they can be accounted for in the longer term, and so they require, additional consideration. And these include measures of wealth, which we know, particularly in older populations, can be an important complement to traditional measures of things like income and education, measures of acculturation, gender identity and sexual orientation, specific measures of social support, and additional environmental measures that go beyond summary neighborhood indicators like neighborhood measures of deprivation or urbanicity. The committee also recognized that it was important to remember that there could be potential harm, that there are potential harms of the status quo in terms of the lack of consideration of these social risk factors in payment mechanisms, and that is that the current status quo creates incentives for providers and insurers to avoid serving patients with social risk factors, can result in underpayment to providers who disproportionately serve socially at-risk populations, with a consequent underinvestment in quality of care, and also the use of a single summary measure capturing the whole population that the provider serves limits the ability of socially at-risk patients to really identify providers who might deliver the best care to patients like them. So those are important harms of the current state of affairs. However, the committee also recognized that it was important to consider that there could be potential harms of accounting for social risk factors. The first of these is that potentially it could reduce incentives to improve care for patients with social risk factors if these differences are taken as givens and completely outside of the capabilities of the healthcare system. They could be unfair in terms of compensating providers who provide high quality of care if the method obscures differences due to poor quality through the creation of these adjusted measures. And any method that holds providers to different standards for socially at-risk populations could create the perception that patients with social risk factors are entitled, or there's no choice but for them to get a lower quality of care. And this, of course, is something that would be an important harm, adverse consequence. So in its fourth conclusion, the committee agreed that it's certainly possible to improve on the status quo with regard to the effect of value-based payment on patients with social risk factors. However, it is also important to minimize any potential harms to these patients and monitor the effect of any specific approach to account for social risk factors to ensure that there are no unanticipated adverse effects that would affecting increasing health disparities, for example. So I think I will now turn it over to Meredith, who is going to talk about the methods.
Thank you, Anna. Can everybody hear me okay? Can you hear me now? Excellent. Yeah. Great. Thank you so much. I wanted to pick up where Anna left off and talk about the specific methods of accounting for social risk factors in Medicare value-based purchasing. In light of the goals, the benefits and risks that Anna outlined earlier, the committee identified a set of methods that could be applied to value-based purchasing programs, including those that are currently in place and being tested by Medicare, but also conceptually a broad array of value-based purchasing programs that might be designed and implemented in the future. In doing so, the committee recognized that any approach to accounting for social risk factors will interact with the underlying incentive design and affect both the risks and benefits of accounting for social risk factors, and so that when CMS considers the appropriate method of accounting for these risk factors, it will have to weigh the specific balance of positive and negative consequences associated with that particular program and the use of a particular set of methods of accounting for social risk factors. The committee concluded that in order to meet the goals identified earlier of accounting for social risk factors, a set of characteristics would need to be in place for any appropriate method. And in particular, the committee identified that the method should aid in the transparency and accountability for both overall performance and subgroup performance. Accounting for social risk factors should increase the accuracy of performance measurement, that is to reduce bias, and also create a high reliability measurement. And then finally, any methodology should improve and at a minimum not worsen incentives for the providers or health plans at issue to improve care, quality, and efficiency, both overall and for socially at-risk groups. The committee identified a set of 4 categories of methods to account for social risk factors, including 10 methods in total. And you will find these methods identified in Table 4.1 of the report. I will briefly cover each of these categories over the next set of slides. First, public reporting methods. These methods included in this category relate to the stratification of publicly reported performance data on quality, cost, patient experience, and other performance indicators. And the first methodology specifically identifies the possibility of stratification based on patient characteristics within reporting units. So, for example, identifying readmission rates for nursing home patients who are socially at risk versus others. The second method is stratification by reporting unit characteristics, and for example, comparing the performance of safety net hospitals with their peers among safety net hospitals versus another comparison that would show performance for other hospitals compared to their peer groups. The second category of methods is the set of approaches to adjusting performance scores for public consumption. These adjustments can be made using statistical methodologies, including risk adjustment for mean within provider differences, and essentially adjusting away the average disparities while leaving differences that deviate from that average disparity. The second approach is risk adjustment that would capture both within and between provider differences and essentially soak up all the association between the social risk factor and performance. And finally, the committee identified the possibility that specific quality measures for socially at-risk groups could be added to the calculation of an overall performance score for providers and health plans. And so, for example, a particular measure of the ability of patients to get discharge information in their native language could be such a candidate measure, just an example. The third category of methods includes the direct adjustment of payment as opposed to adjusting the performance measure for public review. These direct adjustments include statistical risk adjustment, again, in the context of the payment formula without necessarily making that adjustment in the measured performance, but incorporating the risk adjustment into the payment formula. The second method of direct adjustment is the stratification of benchmarks used for payment. In a number of value-based purchasing programs, as you may be aware, there are specific thresholds above which providers or health plans may be deemed to have high performance and thus eligible for rewards. Those benchmarks could be stratified based on both patient and provider characteristics. The final category of methods for accounting for social risk factors really goes back to the underlying incentive design of the particular present and future Medicare value-based purchasing program. First, it has been recognized elsewhere that paying for improvement relative to a reporting unit's own benchmark can, under certain circumstances, help level the playing field, measuring performance against one's own past record. In addition, it is possible that a payment formula could give different weight to performance indicators that are more sensitive to social risk factors, and particularly in cases where those social risk factors may be more difficult or expensive to remediate. And finally, the incentive design could explicitly add recognition for low disparities between socially at-risk and other groups, or for reducing disparities between socially at-risk and other groups as a structural element of the incentive design. The committee concluded that to achieve the goals articulated earlier in terms of improving overall quality, improving equity, accuracy of performance measurement and fairness of payment, that it is likely that a combination of accounting for social risk factors in both reporting and payment algorithms is needed, and that it is possible that in some cases it will be useful to combine methods within a single category and across categories, depending on the specific circumstance. The committee also concluded that when considering the application of methods to account for social risk factors, that some attention must be given to the fact that accounting for social risk factors when looking at resource use or cost may be somewhat different than for quality measurement, in particular because observed lower resource use may both reflect unmet need or the absence of waste, and that disentangling those two potentially opposing forces will be important in order to make sure that incentives for effective and efficient care are maintained. Finally, the committee concluded that any approach to accounting for social risk factors is inherently subject to some uncertainty about how the risks and benefits will materialize in light of the underlying incentives of these programs and in light of the distribution of patients across markets, across providers and health plans. For this reason, continuous monitoring both of the underlying performance trends, but also of enrollment and disenrollment, patient access, other indicators that might suggest the distribution of benefits and harms from accounting for social risk factors. This kind of monitoring will be critical to any program going forward. And now I will hand it back to Don Steinwachs.
Thank you. The next slide in our concluding remarks, we want to make sure it's understood that we have not been asked in the statement of task to recommend whether social risk factors should be accounted for in value-based purchasing or how they should be accounted for. That decision sits elsewhere. And so the committee sees itself as developing information that has been requested, but the use of that information will certainly be shaped by CMS, the Secretary, and potentially others in doing so. What we have talked about with you today is report number 3. We have been producing a report every 3 months. We will be having a report that will come out, the 4th report, in early October, and the 5th report will come out in early January 2017. Just to let you know what is coming is the 4th report is really a report asking for what the sources of data exist now, what new sources might be developed that could be used as part of collecting data on SES factors and making that data useful in ways that will account for or adjust possibly payment and adjust other factors that Meredith went through. The 5th report is rather unique in the sense that it is a report that summarizes and synthesizes the first 4 reports, but also provides the committee with an opportunity to look back and see whether or not that we might think differently at the end of this process about some of the things that were said or different ways to integrate the information that we put forward in the 4 prior reports. So this ends the summary, and you know how to download the report in this slide, and I encourage you to do so.
Okay, great, thank you. So now we will open it up to questions. I ask again if you can type in your questions in the lower right-hand Q&A box on your screen. And also, please identify your organization when you're typing in a question. So we do have a couple that have already come in. The first one's pretty straightforward. It's from Jeffrey Reed. He wants to know, what does the acronym SES stand for?
The acronym SES stands for, is traditionally used in the literature to stand for socioeconomic status, and our statement of task did use that terminology. However, in its deliberations, the committee concluded that we wanted to take a broader approach to thinking about the social factors that could be related to the various outcomes that Medicare is interested in and pays based on. And so that's why we did not use the term SES. We used the broader term social risk factors that encompasses those 5 domains that I mentioned in the review. And you'll also note that we use the term socioeconomic position instead of SES because the literature suggests that it is also a broader term than SES, which has sometimes been linked to a specific way of thinking about social stratification, which is not what the committee wanted to restrict itself to.
Okay, thank you. Next question comes from Arnold Iser. He basically asked, what are the differences between this committee's report and the earlier National Quality Forum's report?
Meredith, could you respond to that?
Sure, I can do my best, although I have to admit a little bit of ignorance, but I can tell you that when the committee approached its task, in particular identifying a set of criteria for through which the candidate social risk factors could be evaluated. We looked at NQF's work, and in fact, you'll find that the way we use the criteria aligns not exactly, but closely with the NQF's work. The work here took a somewhat broader view of social risk factors, as Anna laid out earlier, and so there are some differences, as well as the fact that we took our task to be, I think, a little bit broader than what I know of the NQF's work, to go beyond consideration of risk adjustment to a broader set of methods of accounting for social risk factors.
Thank you. Our next question comes from Deborah Kilstein. She asks, I note that you do not include food insecurity as a social risk factor. Could you please address not including this factor given the direct impact on health conditions such as diabetes?
Anna?
Well, we were focused on a more distal set of social risk factors, and so one could envision food insecurity as being a consequence of some of the more distal things that we focused on, including socioeconomic position, neighborhood context. So that's why it's not included on the broader list. There are many social processes through which the effects of social risk factors operate, but we were trying to capture a relatively synthetic set that would be driving a lot of the mechanisms in order to be able to, come up with indicators that could be practically used.
Okay, our next question comes from Arlene Ash. She asks, how does living alone or poor social supports fit into this framework?
So as you can see in the framework, these are two, so there's a dimension that's called social relationships, and living alone or other measures of social support are indicators of that domain. So we certainly consider social relationships as one important category of social risk factors that could be related to these outcomes. So living alone is one of the indicators of social relationships that we identified as something that could be captured in relatively short term.
Our next question comes from Nancy Foster. She asks, is there any reason that these recommendations would not or should not apply to other programs that use quality or other performance measures? For example, insurers assessing which organizations they will contract with or treat as the preferred provider.
Meredith, would you take that?
Sure, and I guess I would note that these are not recommendations per se, but they are the conclusions of the committee about a set of trade-offs. and a way of thinking about accounting for social risk factors. And so I would agree that, yes, because the committee really looked very holistically at the relationship between social risk factors and health outcomes and other performance indicators, that this does take a broad view. In many of the sort of worked examples in the report, we focus on specific Medicare value-based purchasing programs, but the intention is to be broad here because for even given our charge, we believe that there are future programs that were intended to be addressed by the work here as well. So we hope that it does have a very general framework and a broad applicability.
Our next question comes from Ann Wynn. She asks, are there existing platforms for accurate and reliable reporting? CMS warehouse data alone, for example, is not necessarily granular enough, and maybe this will be in your fourth report. And she's with Baxter Healthcare.
This is Don. We will be looking at it in the fourth report because there are a range of data issues in terms of both availability, way in which things are defined, the reliability and consistency of the data, and so that report will delve into that. At this point, we have not done that yet.
Our next question comes from Nancy Garrett. She asked, what other examples of additional measures for providers who serve vulnerable populations did you discuss?
Meredith, do you feel you can add to that?
I think it's an Anna.
Anna?
Well, we have not considered specific measures yet. This is the topic of the fourth report. We did consider a range of domains and concluded that the 5 that we settled on pretty much capture the range of mechanisms through which social factors affect these outcomes. So that each of them is actually quite broad in itself, and so across the 5 of them, we felt that we were capturing pretty much everything that we thought was important.
Our next question comes from Shoshana Sofier. While it is hard to change social factors, is it impossible for healthcare to take them into consideration in their interactions with patients in order to reduce their potential negative consequences? And did the committee address these possibilities and how?
That's a very important. Yeah, go ahead, Meredith. Go ahead.
Sorry. Anna and I both jumped in because I would say we had many conversations about this, and you'll see in the report those conversations reflected. Ultimately, this report is about the tensions involved in accounting for social risk factors while aiming to improve quality overall, as well as reduce disparities, maintain both accuracy and fairness in the measurement programs. And so this question of what providers and health plans who may be subject to these payment programs can address in terms of the consequences of social risk factors is critical, and it's precisely maintaining incentives for these reporting units or contracting units to identify and act on those opportunities that is the critical source of the balance we're trying to achieve in identifying appropriate methods to consider for accounting for social risk factors.
So just to add briefly to that, it's clear that there's a continuum in these social risk factors in the extent to which they can actually be modified by the healthcare system or addressed in other ways via tailoring the healthcare in some ways to overcome the impact of that factor. And the committee was very sensitive to that, as Meredith discussed. We did identify these very distal factors as factors that are probably more difficult for the healthcare to act on. At the same time, because it is also true that the healthcare system can tailor its care so that it overcomes the impact of some of these factors, for that reason, as Meredith noted, we reviewed not just adjustment, payment adjustment, and risk score adjustment strategies, but also stratification, so showing the outcomes by levels of the risk of the social risk factors as a way to be able to capture the providers that are actually able to do better with certain populations and be able to monitor that and have everyone be able to see that information.
Our next question comes from Caroline Fitchenberg. Did you consider exposure to racism and discrimination in addition to or instead of race and ethnicity?
That's another very important point. We certainly consider that one of the reasons why there are race and ethnic differences in health has to do with the impact of racism, both outside and within the healthcare system. So that's certainly one of the mechanisms through which these factors could affect the outcomes that we're looking at.
Our next question comes from Martel Hexa. So many social risk factors such as income, education, housing, neighborhood structure, et cetera, are directly impacted by policy. What is the role that policy and legislation plays in this criteria framework?
Well, there's certainly many, many policies that are outside the healthcare system that affect these factors, as you note. And that was, the scope of our scope of work was to focus on the extent to which these factors should or should not be accounted for in payment mechanisms. But certainly we recognize, precisely the fact that they need to be considered is because many of them lie to a large extent outside of the purview of the healthcare system and therefore need to be addressed in other ways. So I don't think the committee's conclusions are inconsistent with thinking about the structural causes and the policy drivers of these distal factors.
Our next question comes from Arnold Iser. He asks, and is there any relevance to Medicaid programs?
This is Don. As you know, many of the individuals who are on Medicare also are on Medicaid or are dually eligible. And so that indeed there are efforts underway at CMS to try and integrate in their thinking how Medicaid and Medicare will work. So I anticipate that they will be taking what they see as useful in Medicare and having to think through how do you adapt that to an integrated Medicare and Medicaid program. So some of this may help shape the future for the dual eligibles, and certainly that might carry over outside of dual eligibles to other Medicaid beneficiaries.
Our next question is from Nancy Foster. She asks, you identify risk factors that relate to the individual patient, such as income, gender, and community factors, such as deprivation and urbanicity. Does the committee believe that the recommendations apply to both types equally?
Can you read the question again, please?
Yeah, you identify risk factors that relate to the individual patient and community factors. Does the committee believe that the recommendations apply to both of these types equally?
To the community and the person.
Mm-hmm. If I understand the question correctly, I'm not sure I understand it completely, but the fact that the community context is one important domain reflects the fact that the committee thought that both characteristics of the individuals and characteristics of the communities and contexts in which they live are important drivers of outcomes. So we think that they're both important. And in fact, some of the, quote, individual level factors like socioeconomic position and the way race is related to health, even though they are technically individual level characteristics, we know that they affect health as a function of the way in which they function in a particular social context. And so they have to do with how people are related to each other. So I would not see this as a very individualistic framework. I think it's quite broad in the sense of looking at social determinants more broadly to encompass characteristics of individuals and society and the various contexts that individuals live and work in.
Our next question comes from Jeffrey Reed. He wants to know, are there any findings regarding the importance or the impact of different factors? And how would a determination be made as to the weight each factor has on quality and efficiency of care.
Meredith, do you want to take this?
Sure, hopefully without sounding too reductionist about it, but findings about the specific relationships between the identified social risk factors and the indicators mentioned and performance measures that's all really quite beyond the scope of this report. This report is really focused on identifying methods and their relative advantages and disadvantages. Likewise, the question of how individual measures and social risk factors should be weighted in any particular value-based purchasing program goes beyond not only the scope of this report, but goes beyond the charge of the committee overall.
Thank you. Our next question comes from Ann Wynn. She asked, the average Medicare beneficiary lives on less than $24,000 per year, and the social risk factors are likely already negative, such as income, dual eligibilities, living alone, deprived neighborhood. How can you weigh bundle payment if most beneficiaries are already at risk?
Meredith?
I'm not sure I totally understood. What was the last part of that? How can you, what to bundle payment?
How can you weigh bundle payment if most beneficiaries are already at risk?
Well, I assume that this question is asking about how can one account for social risk factors when most beneficiaries are already at risk. And certainly it's true that, as you say, there is a large percentage of this population with a substantial number of these social risk factors, but that does not mean that there's not a distribution or an uneven distribution of social risk factors across providers, health plans, and other entities that might be paid or otherwise contracted by Medicare. So the fact that many are at risk, it really is sort of a question of magnitudes and not about whether accounting for social risk factors is critical. If you look to the criteria, we specifically address that there needs to be sort of an underlying rationale for some method of accounting such that there is variability and the factor matters for the specific performance indicators, and that's sort of how we would approach that question.
Thank you. Our next question comes from Caroline Fitchenberg. Did you consider health outcome-specific indicators such as food insecurity for diabetes or housing conditions for asthma, or was that deemed too complex?
So we did, the committee did talk about this. I think our goal was to identify a set of social risk factors that would be related to multiple outcomes. So we didn't go down the path of seeking social risk factors that were very specific to certain outcomes and not to others, because we felt that that would not be as useful in terms of the goals of our report, which are accounting for social risk factors across a broad range of outcomes that CMS is interested in.
Our next question comes from Nancy Garrett. She says, in the National Quality Forum Disparities Committee, we are monitoring the impact of the trial period for SDS adjustment. We are finding that adding SDS factors have a limited impact, perhaps because of the sparse data available. Did you discuss this issue?
This is Don. So as we indicated, report 4 is our report that really looks at the data. And so that we would expect that when report 4 is complete, distributed, and shared with you in early October, that we could have a more meaningful discussion about that. But you do see that we have in report 3 recognized those measures where we think there is capacity now, social risk factors, to quantify them, and those where a further investment is needed beyond what we have now in terms of data and data resources. And there may be others that will be added to that when we look at report 4.
And that's actually the end of our questions that we have right now. So if anybody has another question, if you could please type that in. I will give us another minute or so to see if any more questions come in. If not, we will end the webinar. It doesn't look like we have any other, oh, we might have got one more. Oh, a question just about the slides. Will these slides be available? And yes, we can share them. We can post them up on the website that is up there, the nationalacademies.org/Medicare social risk factors. We will put that up on that website. So this concludes today's webinar. I'd like to thank you all again for joining us. And please stay tuned for the next report that will be coming out in a few months.